Добрый день, уважаемые коллеги, уважаемые друзья. Мы начинаем свое вещание из Москвы, из Московской городской онкологической больницы номер 62. И сегодня мы проведем вебинар, посвященный интракорпоральным анастомозам в лапароскопической колоректальной хирургии. Свое видение представят наши коллеги и друзья из Кореи, из Сеула, из госпиталя Kyung Hee, это профессор Ли, и доктор Эрик Белгерс из Ziekenhuis Zuyderland Hospital из Голландии. Good day, dear colleagues. So we are now broadcasting online from Moscow City Cancer Center number 62. And today we will have a webinar dedicated due to laparoscopic intracorporeal anastomosis in laparoscopic colorectal surgery. And today our webinar will be divided in three parts. First part will be from Dr. Ilya Chernikovsky from colorectal department of our hospital. The second part will be from Professor Lee from Kyung Hee University Medical Hospital. And the last part will be from Dr. Eric Belgers from General Surgery and Gastro-Intestinal Surgery in Zuyderland Ziekenhuis Hospital. И сейчас я хочу предоставить приветственное слово заведующему отделению колоректальной хирургии Московской городской онкологической больницы номер 62, доктору Илье Черниковскому. And the greeting words will be by Ilya Chernikovsky. He is the chief of department of colorectal department of Moscow Cancer Center number 62. Welcome.
Доброе утро, дорогие соотечественники. Всех приветствую, всех, кто к нам присоединился в столь ранний для некоторых час. Актуальна для нас, для всех тема, которую мы сегодня обсудим. Также я хочу поприветствовать наших довольно известных в мире иностранных коллег. I'm glad to welcome Professor Lee and Dr. Belgers, who have responded to our proposal. It's great, and I hope we will spend this hour with great benefit. And I give the floor to my friend and my colleague who organized this webinar, Pavel Melnikov, and welcome.
Thank you, спасибо. Для начала все-таки хочется еще извиниться за некоторые технические возможные проблемы. Это наш первый опыт проведения онлайн-вебинара. Я надеюсь, что все пройдет хорошо. And first of all, I want to say a little sorry for some technical problems because this is our first experience, but I'm glad that all will be good. So, включите, пожалуйста, презентацию. Почему нам важно и нужно говорить о необходимости совершенствования наших техник в лапароскопической колоректальной хирургии? Why it's very necessary to say about necessity and importance of perfection of laparoscopic surgery due to colorectal cancer? Через 2 года мы будем праздновать 30 лет, как мы уже оперируем колоректальный рак лапароскопически. На самом деле мы все делаем одни и те же вещи, за исключением маленького степа технического. Мы не считаем в большинстве своем то, что якобы формировать колоректальный анастомоз важно интракорпорально. In a few years we will celebrate 30 years anniversary as we perform laparoscopic colorectal surgery, and we'll do the same steps, but the general statement is it's not important to perform intracorporeal anastomosis. Но на самом деле даже вот такая маленький технический подход, он может повлиять на очень многие непосредственные послеоперационные результаты. But generally, we can use this approach to solve many problems in postoperative period, such as такие как послеоперационные боли, количество раневых инфекций, частота образования послеоперационных грыж, косметический эффект и продолжительность госпитализации. Such as postoperative pain, surgical site infections, the herniation, cosmetic effect, and the length of staying in hospital. И во главе всего этого, самым главным шагом для всего этого является все-таки умение формировать интракорпоральные анастомозы. And for all of that, we should use intracorporeal anastomoses. Давайте посмотрим, как влияет выбор мини-доступа на интенсивность послеоперационных болей. Мы в некоторых работах не видим никакой разницы между продольным и поперечным доступом. In some trials we don't see any differences between transversal and vertical mini laparotomy. В некоторых работах, наоборот, мы видим преимущество поперечных доступов по сравнению с продольными. In some studies we see that transverse mini incision is better. Также мы особенно не видим существенных достоверных различий между поперечным и продольным доступом по частоте инфицирования послеоперационных ран. We don't see no significant differences between vertical and transverse mini incision in terms of surgical site infections. Но давайте посмотрим на эту очень интересную работу. Она не новая, но мы видим, что доступ по фаланштилю, он не приводит, практически никогда не приводит к образованию послеоперационных грыж. Но его никогда не используют, допустим, при правосторонних либо некоторых левосторонних гемиколоктомиях. If we see in the terms of herniation, we could see that the phalangeal incision doesn't lead to incisional hernias instead of vertical and midline incisions that lead to huge numbers of incisional hernias. Если мы посмотрим на этот интересный метаанализ, он достаточно свежий, мы увидим, что наименьшая вероятность образования послеоперационных грыж именно при доступе по фаланштилю. If we see this meta-analysis in this systematic review, we could see that the minimal probability of herniation in case of phalangeal incision. Итак, мы понимаем, что на самом деле, наверное, для пациента, да и для хирурга, наиболее оптимальный доступ – это доступ по фаланштилю. Но он имеет свои ограничения, если мы используем только экстракорпоральные анастомозы. So we could see that the best approach is phalangeal incision, but phalangeal incision has limitations in terms of some kind of procedures like right colectomies or high left colectomies. То же самое относится к хирургии через естественные отверстия. The same things in natural orifice placement extraction surgery. Существует несколько видов извлечения препарата, но если мы говорим о правосторонних и левосторонних гемиколоктомиях, для нас тут наиболее актуальным будет являться именно формирование интракорпоральных анастомозов. So we have many approaches for extractions. But if we talk about, when we talk about transvaginal approach for extraction, we generally speak about intracorporeal anastomoses. Noses имеет достаточно много преимуществ по сравнению с минилапаротомными доступами именно по частоте нагноения послеоперационных ран. We have many benefits from noses in terms of surgical site infections. We have less surgical site infections, but the same disease-free survival. Так почему же до сих пор в России мы говорим, что нужно как можно чаще использовать интракорпоральный анастомоз, хотя мы знаем, что есть очень много преимуществ. Существует очень много мифов. So why we talk in Russia, in the world generally, about the benefits of intracorporeal anastomosis? Because we have many prejudices and myths. Прежде всего, есть предубеждение, что это ненадежный анастомоз, что есть вероятность контаминации бактериальной брюшной полости, что это более долгий анастомоз, что ему дольше учиться, что есть определенные опасности интраоперационных осложнений, такие как перекрут брюжейки. So first of all, we suppose that this is an unsafe approach, that there is a high rate of bacterial contamination, it's much longer time of procedure, it's bigger learning curve of envelop this approach, and we have some problems in period of preparation, such as twisting of mesentery, for example. Но если мы посмотрим на работы, которых достаточно много, мы поймем, что на самом деле все это мифы, которые нужно просто в себе преодолеть. But if we see in the literature, we could see that there are many trials that ruin these myths and prejudices. Например, крупный метаанализ показывает, что разница между интра- и экстракорпоральными анастомозами в рисках несостоятельности отсутствует. So there is no there is no differences in risk of leakages between intra and extracorporeal anastomosis if we see this meta-analysis. Yes, you could perform intracorporeal anastomosis side to side, end to end. It's not a the key point. Время операции при освоении данной методики, оно на самом деле не больше. Если мы посмотрим, опять же, в эти работы, мы увидим, что как время формирования самого анастомоза, так и общее время операции, оно сопоставимо. So if we see in terms of time of surgery, we could see that if you complete your learning curve, the time of anastomosis formation is the same, and the whole time of procedure is the same. Опять же, опасность бактериальной контаминации брюшной полости, она достаточно сильно преувеличена. Безусловно, что-то такое присутствует, но клиническая реализация бактериальной контаминации не происходит. Если мы посмотрим на частоту образования внутрибрюшных абсцессов, она достоверно не отличается. So the problem of bacterial contamination, it's not so big as we suppose. As we see on the intra-abdominal abscess formation, it's not significant differences between extra and intracorporeal anastomosis. Более того, опять же, интракорпоральный анастомоз, он способствует снижению частоты нагноения раны. Это понятно, потому что мы не идем на компромиссы, мы делаем доступ, удаляем уже готовый препарат, и нам не нужно расширять его, нам не нужно, скажем так, насильственно извлекать препарат. Сам этап мини-доступа, он достаточно быстрый. So, there are many benefits from intracorporeal anastomosis in terms of surgical site infections. For example, we don't need to do a larger incision. We have already complete spacement just for extraction. При операциях, в которых мы задействуем интракорпоральный анастомоз, пациенты испытывают меньшую интенсивность болей. The patient has a less intensive pain scale when we use intracorporeal anastomosis. Опять же, тот же самый перекрут брюжейки, о котором многие говорят, что это является проблемой при интракорпоральных анастомозах. В некоторых работах показано, что это абсолютное заблуждение, и наоборот, при экстракорпоральных анастомозах чаще это случается, нежели при интракорпоральных анастомозах. And the twisting of the mesentery higher in case of extracorporeal anastomosis comparing with the intracorporeal. Интракорпоральные анастомозы при правосторонней гемиколэктомии также имеют массу преимуществ. Это меньшая частота общих осложнений, уменьшение послеоперационного крикотня и меньше нагноения ран. In case of right colectomy, we have the same less complications in terms of less general complications, less the durations of hospitalization, and less surgical site infections. Что же касается кривой обучения, действительно, на первых 25-30 операциях время формирования анастомоза дольше, но, как мы видим по правой нижней кривой, происходит достаточно быстро, и уже по исходу learning curve хирург, активно оперирующий, встает на свою плато. And as we see in this trial, we could see the decreasing length of time of the procedure in the first 25-30 procedures. And the operative surgeon goes on the plateau. Поэтому мы считаем, что вот говорить об этих анастомозах нужно, важно. К сожалению, в России не так много мы уделяем этому внимания, хотя мы видим, что в принципе преимущества у данного подхода очевидны. So that's why we suppose in Russia that it's very necessary to speak about that, because the benefits are obvious. So thank you very much. Спасибо большое. Если есть какие-то вопросы, можете вот задавать онлайн. Наши коллеги, сидящие в нашей аудитории, могут задавать их тут. И пока готовится следующий спикер, следующий докладчик, мы можем некоторые вопросы уже обсудить сейчас. Сейчас нас смотрит порядка 45 человек онлайн, порядка 10 человек в нашей студии. И пока созревает вопрос, я хочу представить следующего спикера. There are about 50 followers by internet and about 10 surgeons here online. And I want to represent the next speaker. Это профессор Кил Yeon Lee. Он представляет госпиталь Kyung Hee, университетский госпиталь Kyung Hee. Также он шеф Humanitas Cancer Center. Профессор Ли является членом различных обществ: Корейского онкохирургического, эндолапароскопического общества, Европейского общества колопроктологов, Американского общества колоректальных хирургов. Он является президентом Корейской ассоциации роботической хирургии, шефом комитета обучения и образования Корейского хирургического общества. В общем, имеет очень много регалий. So the next speaker is Professor Lee. He's the professor and chair of Department of Surgery of Kyung Hee University Medical Center. He is the chief of Humanitas Cancer Center. He is a member of Korean, American, European Society of Coloproctology, Korean Society of Endoscopic and Laparoscopic Surgery. And now he is the president of Korean Association of Robotic Surgeons. And he is the chief of Committee of Training and Education by Korean Surgical Society. Professor Lee, can you hear me?
Yes, I can hear you. How are you?
Thanks, I'm fine. Good afternoon, Professor Lee. Nice to hear
Yes,
you.
it's already 3:30 p.m. So good morning.
Good morning. Good morning.
So can I start
Yes,
my
please.
presentation? Okay. So I wonder if you can see my slide. Can you see my slide?
Yes, we can see your slide perfectly well.
Okay. So I used to use the extracorporeal anastomosis, but I changed my practice a couple years ago because of the incisional hernia. So I am trying to explain the whole story. So I think that gastrointestinal surgery consists of three parts: dissection and division and reconstruction. It's all. So today I'm focusing on the reconstruction after colectomy. Next slide. Next. Next slide, please. The previous one. I cannot see the previous one. There's a time lag, I think. The previous one.
Предыдущий.
The third slide.
This is the first slide. This is the second
Okay.
slide.
Yes,
Third
and
one.
then next.
Next.
I have to wait.
Yes.
No, it's first one. Next. Okay, it's okay. So I have to skip all of this stuff because the PAVR already reviewed all the literature. So I just say that the extrusion side is very important. So the midline incisions got higher rate of, hello?
Continue, please.
Oh, I can see my slides, but so the extraction side is very important. If you use the midline incision, you will get the higher rate of incisional hernia. So I think that you have to you have to retrieve the specimen through the off midline or phalansteal. As you can see, the phalansteal incision is the lowest rate of incisional hernia. Next slide. Because of the, somewhat it's a lack of the visual. Okay. So, and the intracorporeal anastomosis has got some benefits. As you can see this table. So, yeah, smaller incision and another lot of benefits. Next slide. Okay, so you have to understand the advantage of the intracorporeal anastomosis. So this table shows you the incision length is smaller and the incisional hernia is just 0 after the intracorporeal anastomosis because they choose the external site in the phalansteal incision. So you have to choose the phalansteal or the off midline incision is very important to decrease the incisional hernia after the laparoscopic surgery. And next. Okay, here are summaries of the benefits, potential benefits of intracorporeal anastomosis. So it includes the less mobilization, especially in high BMI. You have to mobilize further to exteriorize the specimen. And then you can avoid the rotation of the anastomosis. And then you can get the smaller incisions. And then you can choose the extrusion site with intracorporeal anastomosis in the intraoperatively. And there are postoperative benefits, as you can see here. So such as reduced necrotic use and a faster time to flightus and shorter length of hospital stay, and then you'll get the reduced hernia rate. It's huge for the patients. Next slide. So here they're explained by trocar position. The left side is right colectomy, the right side the left colectomy. So it's really same. I usually use the 5 trocars, and then as you can see this picture. So in right colectomy, I have to use 10 millimeter trocar in left upper quadrant, okay? And in the left colectomy, I have to use the 10 millimeter trocar in right lower quadrant. And usually I use the feather incision to retrieve the specimen, okay? Next slide. So I cannot see the video, that's the problem. So can you see the video? Yeah, you can click number 1. And I can skip this slide, next slide. Next slide. Yes, click number 1. Link my video, number 1, number 2. And number 1 is ileosteectomy. So the standard operation for the cerebral cancer, so we don't usually resect all the right colon, and just the half of the ascending colon should be removed, and then ileosteectomy, and then we have to make anastomosis to the ileum and then ascending colon. I cannot see the video. Oh, so in the folder, there are clips. You can click the motion pictures directly. Yesterday, I've already sent the video file. Today, I've sent already PPT file, but yesterday, we've already sent my videos. Okay, so, and then I prepare my videos first, and then next speaker we'll start his presentation first, and then I'll send my videos. Okay.
Еще раз приносим вопросы за некоторые технические заминки. К сожалению, они случаются, особенно в век интернета. Достаточно посмотреть на выборы президента Соединенных Штатов Америки. И первый вопрос от Купрейчика Василия из города Москва. Здравствуйте, Купрейчик Василий. Вопрос: во сколько начинать делать колоноскопию для снижения риска выявления онкологических заболеваний прямой кишки?
Я могу ответить на этот вопрос. Это одна из тоже очень важных тем, которую мы будем обсуждать завтра на нашей мини-конференции, которая пройдет здесь уже не в режиме вебинара, а так сказать, очно. Дело в том, что принято делить всех граждан, всех людей на 3 категории по степени риска возникновения колоректального рака. И те люди, у которых есть генетические наследственные синдромы, типа синдрома Пейца-Егерца или синдрома диффузного семейного полипоза, относятся к группе высокого риска, а также люди, у которых имеются длительно текущие хронические воспалительные заболевания прямой ободочной кишки, такие как неспецифический язвенный колит и болезнь Крона. Вот эти люди относятся к группе высокого риска, и они должны начинать обследоваться раньше, чем все остальные. В частности, люди, у которых имеются наследственные генетические синдромы, должны начинать обследоваться с 20 лет. Имеется в виду колоноскопия тотальная. Пациенты, у которых длительное течение воспалительных заболеваний кишечника, должны обследоваться начинать обследоваться каждый год после 10 лет течения такого заболевания. К группе повышенного риска относятся граждане, у которых есть родственники, кровные родственники, которые болели колоректальным раком, раком тела матки, раком молочной железы и раком яичника. Эти люди относятся к группе повышенного риска и должны начинать обследование с 40 лет, выполнять колоноскопию, и предварительно делается первичный скрининговый метод. Это анализ кала на скрытую кровь, иммунохимический тест. Все остальные относятся к группе среднего риска, и они должны начинать скрининговое обследование с 45, в некоторых странах рекомендуется с 50 лет, но лучше с 45 по последним данным. Это классические скрининговые методики, это выполнение анализа кала на скрытую кровь иммунохимическим методом, и в случае обнаружения крови выполняется тотальная колоноскопия. Если скрининг успешен, и популяционный скрининг успешен, а успешен он бывает только в том случае, если хороший охват целевой группы не менее примерно 50-60%, тогда качественный скрининг может привести к уменьшению смертности от колоректального рака на 10% как минимум, в том числе за счет профилактических мер, потому что в ходе колоноскопии выявляются полипы довольно часто, и удаление полипов и есть самая главная профилактика колоректального рака, самое основное.
Спасибо большое, Леонид, за обстоятельный ответ. Мы ожидаем видео из Кореи. Я предлагаю тогда подключить нашего следующего спикера, пока мы получаем видео. Следующий доклад будет посвящен интракорпоральным анастомозам после левосторонних гинеколэктомий. Представит его доктор Эрик Белгерс из Голландии, из клиники Zuyderland Ziekenhuis. Это одна из самых больших больниц в целом и имеет достаточно большой колоректальный юнит в Голландии. Чуть более 1150 госпитальных коек, порядка 500 операций по поводу колоректального заболеваний прямой ободочной кишки в год. Является референс-центром по различным заболеваниям. Это желудочная хирургия, пищевод, бариатрия, колоректальная хирургия и так далее. So I want to represent Dr. Eric Belgers from Holland. He is from one of the largest hospital overall, and they have a big colorectal unit in Holland. It's near 1,150 hospital beds capacity, about 500 colorectal procedures per year. Zuyderland Ziekenhuis is a referral center for gastric, esophageal surgery, lung, thoracic, colorectal surgery, and so on. So, Eric, do you hear us?
Yes, good morning.
Good morning, Eric. Good morning. How are you?
I'm fine, thank you.
Oh, we could see you. Hello, Eric. Nice to hear you. Nice to see you. So, please, your vision of intracorporeal anastomosis after left colectomy.
Okay, thank you for the invitation. I was asked to give my daily practice viewpoints about left colectomy and especially the intracorporeal anastomosis. So I made my presentation with, I think, the questions that should be answered. Can I have the next slide, please? So, as mentioned, I work in a large teaching hospital, and we met at the TME course a while ago. So that's our knowledge with each other. It was a good stay for you guys. Pleasant to have you as guests. Next slide, please. I won't be discussing the TME because there's a complete other webinar, but for now, the questions and the goals that I was asked to discuss is the left colectomy, especially intracorporeal anastomosis, and go from basic to advanced. So I didn't make too many slides, so we can have a little bit of discussion and present some videos. Also asked what kind of materials we use. Of course, every hospital and every country has its own energy device and stapling techniques. So I'll just show what we are using, and also some videos I've edited. As known, the left columnar sections are not the most often indications, so I made a couple of videos from different patients for you guys to illustrate that I think are the key points for performing surgery and anastomosis in these patients. Next slide, please. So, of course, the first question always is, what is the evidence about performing intracorporeal anastomosis? This is a paper that was from Surgical Endoscopy in 2018. Myself, as a minimal invasive surgeon for the upper and the lower GI tract, I'm obviously very enthusiastic for performing minimal invasive procedures, but is there true evidence? So this is a paper that was multi-center international audit about looking at the advantages for performing intracorporeal anastomosis. Next slide, please. And what we see then is that there is a visualization about less pain postoperatively and faster recovery, as we know. There are also less complications, but that's not in the group that truly matter. So the 3 Clavin-Dindo and higher, we don't see any differences, for example, for anastomotic leakages. And as always, we say we need more randomized controlled trials to better do research on this question. But I think even if we don't take into account the complications like anastomotic leakage, there are more advantages about performing the procedure. Next slide, please. So I think in daily practice in Holland, our patients have an average in BMI of more than 25, so they're not too slim. And I think in our teaching hospital, we have residents that are well trained in laparoscopic advanced skills due to, for example, bariatric surgery. They perform enter enterostomies in an early stage in their training. And I think that for myself, performing intracorporeal colocolonic anastomosis is one of the more challenging anastomosis. You have already discussed the intracorporeal right anastomosis. I didn't get that presentation, but I think there is advantage for the small bowel to be better presented for the anastomosis than with the colonic anastomosis. So it is truly a more technical, challenging anastomosis. For the anastomosis, I think that with the intracorporeal anastomosis, there might be better visualization and also better tissue handling. You don't need any manipulation above the skin to perform an extracorporeal, and that will also protect the soft tissues and the mesenteric root for not having any tears and hemorrhages and so on. Good exposure, yeah, well, I think so. Also with larger BMI, lots of tips and tricks, of course, to have that good exposure handled. We'll see in one of the videos with a bowel obstruction that with gauzes and so on, that is possible to have a good visualization. And I'm a true believer in the optimal extraction site. There's a lot of discussion also for sigmoidal cancer surgery where you should extract your specimen. I really believe that a suprapubic and Van Steel incision is a cosmetic sound scar, and also with very low numbers of incisional hernias. For myself, I also do always an TME case a Van Steel, except in very slim patients you can do a transrectal resection. So I think that is a benefit that hasn't been investigated well in the other paper, but it's necessary to mention. I think that is one of the benefits. Next slide, please. So this is also a discussion I always have with our residents. What do we actually call a left colectomy? I think it doesn't really matter anatomically. It must be a sound oncological resection. So I will be showing a video that has the second picture, of course, with a true flexure tumor, where the dissection for good oncological resection is at the base of the left colic, and we also take the left branch of the medial colic artery, and then with the vascularity on Drummond's artery, the wandering artery, we can make an anastomosis side to side. With the first and especially the third picture, I think that a true end-to-end anastomosis, circular stapled with transanally put in device would be easier than an intercorporeal colocolonic anastomosis. Of course, with a transverse resection, we don't do that often, but it's the same actually. You can do the same anastomosis. I'll be showing you a bit further on. Can I have the next slide, please? So this is how we position our patient. It's a French position, and as you can see in the picture, the surgeon is in between the legs. I must honestly say that it depends on the anatomy at present. Sometimes you have very low positioned transverse colon. Then it's easier to do the dissection at triceps ligament, deepest point, standing between the legs. But most often I start at the right side of the patient, so where the first assistant with the camera is positioned now, and I'll be there with my first assistant and me as a surgeon. It's an older picture. These are large monitor boxes, but in an endosuite, you're best helped with monitors everywhere, of course, as you know from your own theater. So you can look up and down as easy as possible. Next slide, please. This is a picture from web search. I think that web search for itself is also a very good site to look for laparoscopic procedures to be explained. This is the situation I was working as well. So we always perform a varus needle peritoneum subcostally at Palmer's point, and then the camera around the umbilicus. For a true left colonic resection, I prefer to use my right hand at the C and a little bit higher port placement for my left hand. So that will be in between F and B. But if you're not completely okay with your left hand position, you can also put a trocar in an epigastric position. The D and the E, that's also depending on the patient, at what angulations you might do your transection with your linear endo stapler. Especially with the intracorporeal anastomosis, it's always the angulation that must be best fitted to be in a straight angle, as we see in the videos. Next slide, please. I think that with the dissection and transection issue for doing oncological sound procedure, depends where the tumor is located, of course. In Holland, we don't actually do a complete aggressive D3 lymph node dissection, no para-aortal lymph node dissection. What we do, that's how we explain it for ourselves. We do a high dissection, low transection for the rectal and sigmoid cancers, and a reversed kind of procedure for the left colonic. So we will get the lymph nodes from the lower portion of the IMA, and then take that upwards until we see the left colonic artery being going up to the colon side itself, and that's the transection zone for the left colonic. The left middle colonic artery, that's also a little bit where the tumor is located, if it will be aggressively at the bifurcation or not. The first thing we do is positioning, of course, with an intention to do a medial to lateral mobilization. Sometimes it's not possible, we do a lateral to medial, but mainly the medial to lateral is our well thought out procedure steps in a training hospital, of course. And then we make our first peritoneal incision from the base of the AMI, going up trites and straight up to the colon through the mesocolic route. The retroperitoneum dissection will be blunt. We'll see that in the video. You might get lost there. And of course, left ureter transections have been described, and we've seen it ourselves as well. Very slim patients. You might be thinking about doing a mesocolon transection, and you end up with an ureter damaged. I myself perform a lot of surgery with diathermia, and of course, the advanced both bipolar and ultrasonics. We use Ethicon and Medtronic side by side. Myself, I am a fan for the advanced bipolar, not for the dissection. I mainly do that with the diathermia, but also for the blunt dissection and for the large steps of the resection of the omentum from the colon and the transection of the mesocolon itself. And of course, a linear endostapler, that's a necessity for an intracorporeal anastomosis. Next slide, please. So, what types of anastomosis are there being described for left-sided colo anastomosis? Extracorporeally we know, but intercorporeally you can do it side-side, end to side, side to end. With the side to end or end to end, you can use a long shaft from a stapler, but I'm not a large fan of that. I prefer to do an intracorporeal linear anastomosis, and that is almost always an isoperistaltic or endoperistaltic kind of anastomosis. In my preparation for this presentation, I found a nice article in Einstein, Sao Paulo, that describes it nicely with video step by step. Nice to look into it. Next slide, please. There's also another technique, a modified book binding technique. I'm not going to explain step by step what kind of stapling you'll be using, but in my hospital we also have to take into account the costs. I think that when you do this stapling technique, there are multiple firings, and I think with a 2 or 3 actually staples being used for the ESO or antiperistaltic anastomosis, you will end up with a good anastomosis as well. I'm not familiar with this technique. I know that in the Asian countries there are also more delta-shaped anastomoses being made, also for gastric cancer, but that's something that we are not common to use this technique in Europe. Next slide, please. So, what kind of instruments and materials we'll be using? We use regularly the 30 degrees camera. We use reusable and disposable trocars, of course. We do have the 3D Olympus, but I myself am not a fan for 3D because, yeah, I haven't been performed many procedures with 2D. I'm used to that, but for the residents, they find it beneficially. In the materials being used in dissection, already discussed, and for making the anastomosis, we use the linear powered stapler from Ethicon with the gripping cervix technology, and for the needle holder, we use the Escalab and then the regular instruments. Closing the defect, we started using the V-lock a couple of years ago. Before, and we of course did it with the Vicryl running suture. And also what I found during my own training beneficial, and I still use it, is using the endoclose from Medtronic. We'll see that in the video with a trocar placement with a Vicryl suture to elevate your anastomosis, that you look into the defect. I mainly don't put too many trocars in, so I don't, if I have an easy case, I don't use an extra instrument for helping out, and then I put a endoclose straight through the abdominal wall to elevate the Vicryl suture. We'll see in the video a bit later on. Next slide, please. Can you pause the video? Sorry. So, if you pause it for a minute. So, if you don't pause it, I will explain quickly. This is an elderly patient, large BMI with an obstructing tumor in the just post-flexure location, as you saw earlier. There was a large bowel obstruction and distension of the transverse colon and almost complete circumblowout. So we did a visualization with the gauzes, as you see, and now we started off by opening the peritoneum from a medial to lateral aspect, from the base of the IMA to trites, as we saw. This is the blunt dissection. I prefer the ligature. That's what we have as an advanced bipolar. I always have to look what side the best blunt dissection might be. You can end up lower or higher. The next thing is, when we found the inferior colic vein, we make a hole in the mesocolonic, transverse mesocolonic location to end up in the retrogastric area. And as you can see a bit further on, you see that with tissue manipulation, you can see the angel hair kind of bordering from the mesocolon and the pancreas that's down below. Is it possible to hold the video for a minute? When we made the retro-mesocolonic dissection to the lateral border, then we just have the vein. It's not necessary to transect the vein, but it's in our regular step-by-step approach for also left colonic flexure mobilization, so we always transect it. In this case, everything was very liquefied, so we didn't do the transection even further, but I transected with the ligature. Don't use the hemolocks for the vein. And when this one is transected, then the retrocolic plane and also the access to the retrogastric area can be elevated as a kind of V shape, and then the deepest part of the transection has been completed. And then just staying on top of the pancreas, a bit further on you can see it even better. You can take down the visceral peritoneum, also from the upper part of the mesocolon from the transverse colon. And as you see, I don't use an assistant. I think that for the video to show you that might have been better, but this is what I had recently operated on, so I edited this video. And then we just continue going on to the lateral part. The next step will be the dissection of the left colonic artery. As you see, you can see that the elevated fatty tissue is the anterior border where all the lymph nodes are from the roots of the inferior mesenteric artery. We don't go all the way down to the aorta. It's close by, but we don't do a true D3 dissection. We think in Europe, Holland, that we are doing more damage than good by adding lymph nodes dissection over there. And that's, of course, a discussion how far you should go. So I've transected the left colic artery, and even then we get some more tension release. We can elevate the window a bit more, and then we follow the pancreas and transect the transverse colon, the cranial part of it, of the peritoneal visceral peritoneum. And by manipulating the tissues, you can see where you can go to. We hardly see any pancreas injuries. There's also discussion for this kind of approach, as mentioned in papers. We hardly see it, but you have to take into account when you do the retrocolonic dissection that you don't end up below the pancreas, of course. And if you run upwards, then you might be in problem. So this is the video I wanted to show you for the dissection. I didn't put in the left colonic artery. I think that for you guys, the left part of the middle colonic artery, but I think that you will understand it will be the same as we did for the left colonic. Next video, please. And before we start running it, if you pause it. So we use ICG. This is still picture with the overlay from Olympus. And you see in the, just a little bit to the right in the picture of the center, you see the dissected mesocolon. And we use it now regularly. Not for every patient. We are still putting it in for the finance to get it for every patient in. Use ICG for the perfusion. So if you can run this one. Of course, there is discussion if it really... Oh, okay, you understand that everything went green. So this is an antiperistaltic anastomosis. Understand that we can't stop. So what we see now is the transverse colon. And the stapling lines are in the left top. This is the descending / sigmoid colon. There's a video of my colleague. He is more enthusiastic about the harmonic, ultrasonic the dissection device. Make 2 holes. And then this is what I mentioned earlier for the linear anastomosis. You have to be a good angulation for your 12 trocar to put it in. Always make the angulation about 6 centimeters from the top to have a good anastomosis. What we now see is the ficral stitch I was explaining earlier. So that doesn't do anything for the anastomosis itself. It's not not there for any better sealing or anything. It's just to elevate the anastomosis. I think in this video you already see that there's a good visualization, but especially when the tissues are a little bit laying on top of each other, you can elevate the upper corner. As seen now. And this is something what I do with the endoclose. My colleague now put an instrument in for his colleague. And then we always start at the lower portion of the anastomosis, the lower part of the defect. That's always the most difficult one. So we start off with that with a V-lock. And we start first crossing the stapling line, not exactly straight in the corner, but first have a good start on the stapling line. I myself always put a needle already through the eye extracorporeally. Trick I saw from Walter Brunner from St. Gallen. And now it's just a running suture all the way up and also on top crossing the stapling line. In Holland we say this is like an easy anastomosis. And of course, that might be much more difficult in a more obese patient, where there might be some tension to get the colon sides opposed. Of course, there shouldn't be tension on there, but sometimes it's not that easily opposed. Continues with a couple of extra stitches, and from the Vila company they say you have to do 1 or 2 running sutures backwards, that you get a locking, extra locking. And then we cut down, and in this procedure we don't close the mesenteric defect, it's opened. But as you can see with the stomach inside, you know that probably this anastomosis will be on top of, a little bit above Treitz ligament, and that's an important thing we will see by pitfalls. Next video, please. In the next video, this is a patient I just operated on recently, and that was a obese patient with diverting end colonic stoma for a complication of rectal perforation. So they are opposed in an isoperistaltic side-side anastomosis positioning. I myself use the hook to open, as not using the harmonic for back cutting. And as you see now, I had a small problem with the length. I thought I was more further away from the top, but with an anastomosis of 3 to 4 centimeters, I was happy to continue. This time I didn't use the V-lock because I thought, or the Vicryl, I thought I had a good visualization. So start at the bottom, crossing. First one is over, and now you'll see that I have put a lock outside, so I just have to get the needle through the hole. You see it running over my needle holder, and then it's kind of a double lock. It's a trip I saw in a single port fellowship in St. Gallen, and I have never had any problems with it. You might discuss that there might be some relaxation in that corner, but I didn't see any anastomotic leakage at that side. So I think it's a sound trick. And then the same, manipulating the colon or the thread and needle holder to have a good running suture. With the isoperistaltic and antiperistaltic anastomosis, as I've shown you in these 2 videos, I think that in all cases we can end up with a good anastomosis. We need another kind of type anastomosis. I think that the modified binding technique is very complex anastomosis to be made, to understand it technically, and also to perform it technically. I didn't do it myself, of course. And I always run 1 centimeter or a bit more from the crossing stapling. Always happy with a stitch more than less. Okay, next slide, please. So I think that all will be finishing. And the tips and tricks for the resection is, of course, good oppositioning. And then you may get some length from the hepatic flexure mobilization, also sigmoid colon. If I know there's a bulky tumor in the flexure or descending, and you see already in upfront CT scanning that there might be a length problem, then I always do a complete sigmoid mobilization, lateral to medial, and starting and told, so you get some good opposing colocolonic anastomosic positioning, but always take into account that the anastomosis might be centrally located in the abdomen, with a problem about the Treitz ligament being on top of it with the internal herniation. So you should close the defect then. Normally we don't do that. Trick is the Vicryl stitch for elevation. You can use your assistant to elevate, as you saw in the first anastomosis video. I use the endoclose as mentioned. With performing an isoperistaltic side to side, you always put the distal colon part laterally So you look into the defect. If you oppose it the other way around, you're always looking over your colon. That's not easy. I think that that should be a very important step to good positioning for nice anastomosis. If the anastomosis, putting a technique together, is difficult, then the outcome will obviously be also problematic. Might be problematic. Putting in a stapler, I always do the large part, so that holds the staples itself. Put it in a distal part, so when you advance the device, that stays on the device, it won't slip off. And then put the metal blade in the proximal colon part, then you can put some tension on there, you retract it over your staple. If you do it the other way around, then you might lose the transverse part of your anastomotic site when manipulating to get through the descending colon part, the whole of the colon part, the rectotomy. And the V-lock starting dorsally. Next slide, please. So this will be my last slide. What are the pitfalls from the anastomosis? It's always taking account the internal herniation. I think I already mentioned a couple of times. We don't do it regularly, closure of the mesocolonic mesenteric defect, but you should do that, I think, when you see that tricep ligament is above, so cranially, of your anastomosis, because the small bowel might herniate then to the old left flexure side, and that might give some bowel obstructions later on. I'm not too worried about fecal contamination, but in Holland we don't use the bowel preparation for these kinds of surgeries. We do it, of course, for the supposed deviated rectal dissections. We're discussing about mechanical bowel prep and selective bowel decontamination, but in Holland we don't have a true understanding if that should be performed every case. I think if you do an intracorporeal anastomosis, it might be better to have some sturdy features in the colon instead of some liquefied stools we see with bowel prep. Taking account rotation, of course, and I myself am more fan of the isoperistaltic, because if you try to do an antiperistaltic and you end up with tension, then it's always on the corner where you make your V-lock, and it might open up your anastomosis over there if there comes some tension on there. So I think that this is a presentation I thought that I would answer the questions I was asked. I'm not sure if there is a possibility for interaction, but I'm, of course, much obliged to answer some questions.
Okay, Dr. Belgers.
Hello.
Once again, thank you very much for your wonderful presentation. It was amazing. Thank you for sharing your experience. We have some questions for you. First question, do you experience with some problems with using V-lock for closing for bowel incision? Because in Russia, V-lock not approved for bowel suturing.
Yeah. So the question is, enter some problems with V-lock?
Yes.
It's correct. We started using it years ago, and then also were mentioned by the manufacturer that it isn't approved to use in anastomotic suturing. But at this time, all anastomoses are sutured by V-lock in Holland. I can't speak for my colleagues in other hospitals, of course, but in our hospital we use the V-lock for the gastric cancer resection anastomosis. We use it for the bariatrics. We use it for the colorectal resections. So it was a question a couple of years ago, but now it's common practice to use V-lock actually for everything, even if there might be an iatrogenic small bowel injury or anything. We're more used to use V-lock than cross-stitch fibro, but also depends on which one of those is easiest. And in our registration, we have good Dutch complication registration. we always look into the anastomotic leakage, of course, and we never saw a trend. We didn't completely look into it, but we didn't see a trend before using the V-lock in our anastomosis and afterwards. So that indirectly says we don't see problems with that, not in the daily practice and also not in our data.
The second question will be about suturing. So you advise to start running suture from down to up, yes?
Yes, correct.
One round layer.
One layer, yeah, correctly. I was trained before laparoscopic colorectal surgery was implemented in our hospital a while ago, and my older colleagues taught me to do a double layer suturing, completely hands-on, of course. But I think that is one of the things we left out when we implemented laparoscopic colorectal surgery. Just like with an appendectomy, you don't put the stump of the appendix away with the suture anymore. In laparoscopy, you just throw a loop around it. Same procedure, I think. Same thought.
Okay. Thank you. Another question, please.
And I have a question. Do you use antibiotic oral preparation before operation?
Well, we give prophylactic antibiotic, so that's metronidazole and cephalosporin. Discussion in our hospital if you should give also IV gentamicin. That's because of our cultures that are taking with anastomic leakages. That's a discussion we have in our hospital. The Dutch guidelines don't say anything about that, if to put it there, gentamicin, but that's IV prophylactic. There are papers out there for bowel decontamination. Well, actually, we are just waiting for better papers to come out if we should take that in account. At this time, we don't do it. I know there are hospitals in Holland they do. I met a couple of colleagues from the UK in the faculty side that they talking about the gut, the bugs in the gut, that might be a benefit to do so, but we have not implemented it yet. But I think that's something that might change once more in the near future.
Окей. У нас еще один вопрос от наших коллег из Израиля, из Иерусалимского медицинского центра ЗИФ, от Бенджамина Раскина. На регулярной основе вы готовите толстую кишку перед лапароскопическими резекциями кишки? So we have one more question from our colleague from Jerusalem ZIF Medical Center, from Benjamin Raskin. Hello, Benjamin. Do you prepare bowel on a regular basis for laparoscopic colonic resections?
So, thank you for the question. So I understand correctly, the question is if we do bowel preparation.
Bowel preparation, yes.
Yeah.
I think in that way.
So, in our enhanced recovery program 2.0, so to say, beforehand there was in our protocol bowel decontamination, bowel preparation, but we saw a lot of fluid problems at that time, and we stopped a couple of years ago. So the bowel preparation for itself, we just do it with a TTME, where we want to have upfront decided to put a diverting ileostomy in, but for the other cases, we don't do bowel preparation. Do you guys do it? Can I ask a question?
Yes, sure.
Do you perform selective bowel decontamination and bowel preparation in Russia and in Seoul? And
yes, we do this. We do mechanical bowel preparation and oral antibiotics.
Okay. And
we don't have a connection now with Seoul, but I know that in Seoul they don't use antibiotics.
Okay. Okay. I think performing surgery in Asia and Europe, there are different patients, different bugs, different cancer types.
Yes. Есть какие-нибудь вопросы у вас? Да, да. So, Eric, I want to say a big thank you. Thank you very much for sharing your knowledges. It was wonderful to spend the time with you, with your beautiful presentation. Thanks for your time. And now we have a video from Seoul. Hopefully we get it. Thank you very much, and see you anytime in Moscow.
Okay, thank you very much.
Thank you.
Have a good webinar.
Пригласим обязательно. И сейчас нам удалось достать секретное видео из Сеула, из Кореи, то, которое не удалось загрузить нам в первую презентацию. И опять у нас онлайн профессор Кил Yeon Lee из университетского госпиталя Kyung Hee, который представит видеоматериалы, помогающие нам при формировании интракорпоральных анастомозов после правосторонней гемиколоктомии. And now I hope to hear the Professor Kil Yeon Lee from Seoul with a video presentation of intracorporeal anastomosis after right colectomies. Professor Lee, can you hear us?
Okay.
We can see the video.
Right now.
We can see the video.
Yes. Intracorporeal IC first, please. So can you play the intracorporeal IC? Oh.
Поставить первое видео.
So I can see you clearly now. Okay, great.
We've got the video.
Intracorporeal IC, please.
Should we start the video right now?
It's just 6-minute video. Okay.
Пусть там порты пока поставят все.
I can hear you, Pavel.
На самом деле, вот и по нашей практике, именно при правосторонней гемиколоктомии как-то очень очевидное преимущество, поэтому, на мой взгляд, это видео представляет особый интерес. In our practice, we have seen much benefits in intracorporeal anastomosis,
Right. So, can you play? Okay, I can see it. So, I'm dividing the mesentery of the ileum. So, using 1000i harmonic. Usually, I don't apply the clips or hemolocks. So, to divide the ileum, I use blue cartridge and close it, and you have to wait for more than 15 seconds. Why? You have to spread out the fluids and then flattening the ileum first. This procedure, waiting, make the staple formation very clear, so it's safe for the patient. And then divide the mesentery of the ascending colon. See? So I think that you can see the marginal artery of the ascending colon here. I'm dividing the surrounding tissue of the marginal artery and then divide it without clipping. And then divide it further and all the way to the colonic wall, just like this. Okay, and then for the colon, I use gold cartridge. And then again, you have to clamp first. And then check the end of the colon is included to the cartridge. Okay. And then clamp it first. And then wait for more than 15 seconds for the safe formation of the staples. And then divide it. Okay. And then this is the end of the terminal ileum. And then make a hole in the end of the divided step line, divided like this, and there's making a hole. And then this is the ascending colon, and then making a hole with harmonic scalpel like this, and then like this. You can use the stapler as a grasper, like this. Usually I don't stitch around these two ileum and colon, and just insert the cartridge like this. It's much easier than making a stitch like this. So as you can see, it's not that quite difficult. Okay. So it's isoperistaltic, functional end-to-end anastomosis, and then close the cartridge, clamping it, and then wait for more than 15 seconds. And then firing it. So, and you have to check if there's a bleeding from the step line. If there's no bleeding, so I usually use Stratafix, it's barbed stitch. So it makes stitch very easier, suturing very easier. Laparoscopic suturing is quite easy with this barbed stitch. So I usually close this common hole with this barbed stitch, Stratafix 3O PDS. Okay. And then usually with this one stitch, you can make a 2-row anastomosis. See? And then first it is whole layer suture. And then closing the common hole like this. And then this is the second row stitch, cerebromuscular suture. So it makes the anastomosis more safer. And it's quite easy. So with one stitch, you can make the 2-row stitches like the hand-sewn anastomosis. It's a cerebromuscular second row suture. Okay. Then, as you can see, the ileum and then the colon closed with this barbed stitch. And then cut it just above the colonic wall, the ileal wall, and that's all. Usually I don't, this repetition, so you can, I'm finished. You can close this video, please. Do you want to see this video again? And then do you want to see the next video? Okay, next video. It's for the, it's T transverse colon, and then it's the ileum. And then hold the transverse colon like this, and then the assistant hold the momentum like this. And then it's the same. So make a hole in the ileum side using harmonic scalpel. Okay. Repetition. And then, so at least centimeter you need. So making a hole here. And then from the division end to the hole, usually, you need 10 centimeter. And then make a hole like this. And then the same. For the anastomosis, I usually use a blue cartridge. So, and insert the anvil through the ileal hole. So I'm trying to insert the anvil through the hole like this, and then, grab it with the grasper, like the grasper. You can use it like the grasper, okay? And then open it, and then insert the cartridge to the colonic hole, like this. And then make it parallel. It's a good position. And then check. And then wait for more than 15 seconds and then firing it. It's the same. So see if there's a bleeding or not. If there's no bleeding, you can close the common hole with the barbed stitch. It's the same. Okay. And then it's the first row whole wall stitch. And then, you have to pass the needle through the loop. You don't make the nut. You don't need to make the nut with the bob stitch. So it's a 3-0 Stratafix, the PDS. And then, it's a whole wall stitch with a bobbed stitch, okay? So it's not that quite difficult, as you can see this video. Okay, step-by-step method. So I don't edit this part. It's unedited video with the suturing, so you can see my real technique of the anastomosis. It takes usually less than 15 minutes, sometimes 10 minutes, usually less than 15 minutes. With the new technology, the intracorporeal anastomosis is not that quite difficult. So older times, like 10 years ago, the staple is not good. And then suture, you have to make all the nuts. It's very tedious job. But as you can see this video, it's very easy. That's quite difficult. So if there's a benefits of the intracorporeal anastomosis, why not? You can try like this. So, but this is the last part of the first row. So you have to check if there's a remaining hole or not. See? And it's probably there's a small hole there, and then we have to close it with one more stitch suture. Okay. And then from now on, this is the second row stitch. Okay. Seromuscular stitch, suture. And it's unedited video. Then you can see the whole procedure. Yes, seromuscular suture. And then direction of the suturing is exactly opposite of the first row. And then we have to go up to the colon wall from this side. Okay, it's kind of unedited video, and it takes only 8 minutes to make this anastomosis. So if you have the prejudice, the intracorporeal anastomosis is quite difficult and tedious and dangerous, but it's not. So with new technology, new suture materials, and new stapler, it's quite easy, and you can do it very fast and safely. See? So it's unedited video. So it takes less than 8 minutes. So you can believe me. Probably this is the last stitch, and then you just cut the stitch just above the colon. That's all. Okay. So there's a beautiful anastomosis is done with this technique. Okay. So, and then, yes, I'm done with this, my presentation. Any questions?
Yeah. Hello once again. Thank you for wonderful presentation.
Okay.
Thank you for sharing your knowledges and your skills. We have some questions here. So, Professor Lee, for example, if I start my intracorporeal anastomosis, what do you advise? 1 or 2 raw suture, and what material? V-lock or what kind of you use, for example?
Yes, I always use 2 row stitch with Startafix 3.0 made by Johnson & Johnson. So if you make the common hole very small, like my video, the only one stitch is enough to make a 2-row stitch. So yeah, it's not that quite difficult.
Okay.
Mm-hmm.
Do you put a suture on the opposite angle of the anastomosis?
Sometimes. Yes, I understand. There's a that's the weak point, but usually I don't. So nothing happened. So
I see.
mhm.
The provoke question. What do you do if there is a bleeding from the anastomosis line?
I just cauterize it
Just
with the
what?
spatula type. Cauterize.
Cauterize. Okay.
Yeah, with a monopolar, the spatula type monopolar device.
Okay. We have a question from Jerusalem Ziv Medical Center from
Okay.
Benjamin Ruskin.
Mhm.
The question both to Professor Lee and Dr. Chernikovsky. Based on your practice, if there are any differences in outcomes after either versus antiperistaltic anastomosis, and your personal preference.
So no, there's no difference between antiprostatic and then isoprostatic way. But usually I prefer to do the isoprostatic, but if you do with the descending colon, so in that case, the antiprostatic is much easier than the isoprostatic. So it depends on the location of the tumor. Okay.
Yes.
Mhm.
Dr. Chernikovsky now in the operation room, and I want to ask for them. So he prefer isoperistaltic anastomosis. The key point you save one linear stapler, and the same it doesn't matter of the length of the bowel in case of right lines. And the outcomes the same. The leakages, the morbidity are the same.
Right.
One more question. Да. То есть, если есть, okay. So the question in two parts. The first part is do you routinely use gold cartridge for dividing of ileum, transverse colon. Да, он сказал, он постоянно использует. Yes. The first question has been answered. And the second question, will you perform intracorporeal anastomosis in case of small bowel obstruction due to cancer obstruction?
For me, so it depends on the situation. If there's a lot of dilated bowel, it's not easy because of the abdominal cavity space is so small. In that case, you can exteriorize and then make a you can do the extracorporeal anastomosis. So not mandatory. So you can understand the situation and then you can choose which way is the better method.
Okay.
Mm-hmm.
I want to say that we have about 70 followers due to our conference, about 60 followers in the internet and about 10 listeners here. So, Professor Lee, thank you very much for your time, for your presentation.
Thank you.
There are a lot of interesting in our webinar. So, one of the key points it's you and Eric Belgers. So, thank you very much.
Thank you for inviting me here. Okay.
Let me finish the conference. Thank you very much for being with us.
Bye.
Goodbye, Professor Lee. Goodbye, Eric.
Bye.
Итак, спасибо большое, что были с нами на нашем вебинаре. Это наш первый опыт. Я надеюсь, мы будем транслировать этот опыт и улучшать его. Спасибо большое ребятам из медстудии за техническую поддержку. Она была неоценима. И, скорее всего, без них ничего этого не было. От себя хочу добавить, что действительно интракорпоральная анастомоза – это становится неотъемлемая опция любого хирурга, который занимается профессионально хирургическим лечением рака ободочной и прямой кишки. Все взаимосвязано, и, казалось бы, такие мелочи, они способны как минимум улучшить некоторые показатели, а у ряда пациентов избавить их от повторных операций по поводу вентральной грыжи. Спасибо большое всем.